Okay, today we're going to be talking about all of hematology for the pediatric board review, and we're going to go through this at I apologize, a fairly blistering race to try to get through the various topics that you might need to know for your board exam. This is the lecture outline. To begin with, we're going to talk about how to interpret a CBC and the basic meanings of the various indices that you get other than just the hemoglobin and the hematocrit. We're going to go on then to talk about anemia. We'll then talk about neutropenia as the primary low white blood cell abnormality that you see, and then we'll talk briefly about bone marrow failure, both acquired and genetic syndromes, and then finally we'll touch base on hemostasis and platelet disorders. So as you can see, we've got a very broad agenda for today. So let's start with CBC. So this is a fictional CBC from a patient with significant anemia, and as you can see, when you look at a CBC, you get more than just the 4 values or 3 values that you typically write down on your notes when you're hurried for rounds. In addition to the white blood cell count and the hemoglobin and platelet count, you get a red blood cell count, a MCV or mean cellular volume, an MCH or mean corpuscular hemoglobin, MCHC, which is a mean corpuscular hemoglobin concentration or hemoglobin concentration per red blood cell, an RDW, which is a red cell distribution width, of course a platelet count, and here I've included a retic count and an absolute retic count, which is the absolute number of retics, similar to an absolute neutrophil count that you would get when you're looking at oncology or other services. So the reason they include these is not just because they can, but because they actually mean something, and it might help you interpret why your patient is either anemic or otherwise has an abnormality in their CBC if you understand the meaning of these various indices. And specifically, I highlighted here the ones that you are probably least likely familiar with the exception of the platelet count. The mean corpuscular hemoglobin, the mean corpuscular hemoglobin concentration, the RDW, and the absolute number of reticulocyte count. So if we look at these various indices, first of all, the mean corpuscular volume is essentially just the size of the red blood cell, or how much volume is contained within that red blood cell. And it tells you a little bit about the etiology of anemias or potentially about bone marrow failure. So if you have a small red blood cell size, that typically means a problem with synthesis of hemoglobin. So things like iron deficiency or thalassemia would be suggested. Alternatively, if you have a normocytic red blood cell, things like anemia of chronic disease, acute blood loss, or hemolysis might be indicated. In the rare cases, in pediatrics at least, that we see macrocytic anemias, the most likely causes would be either folate or B12 deficiency, which is quite uncommon in pediatrics, and then bone marrow failure, which is also uncommon, but actually less uncommon than folate and B12 deficiency in pediatrics. And then the mean corpuscular hemoglobin concentration provides you a little more information directly about hemoglobin synthesis. So if your MCHC is low, we refer to that as being hypochromic. So a low MCHC would tell you iron deficiency, thalassemia, or anemia of chronic disease. Normochromic, meaning a normal MCHC, would be associated with either B12 deficiency or folate deficiency, and the reason those are normal in that even though there's a problem with red blood cell synthesis is due to macrocytosis of the red cell. And then anemia of chronic disease may also be normochromic or hypochromic. And then hyperchromic, meaning a high concentration of red blood of hemoglobin, is typically when the cell is dehydrated, and that is most notable in hereditary spherocytosis or sickle cell disease. And then the RDW, which is just really a measure of how many sizes of red blood cells are present during a CBC. And so if you have a high red blood cell count, we call that, or a high RDW rather, we call that anisocytosis. And that just means variation in size of a red blood cell. And that is most common in problems of synthesis, such as with iron deficiency or B12 deficiency. And then these others are typically associated with a normal RDW. And a normal RDW doesn't imply a normal red cell size, it just implies that they're all the same size. Reticulocyte counts, you may be more familiar with than these other indices. These are reticulocytes, or red blood cells that still have RNA in them. They typically mature within 1 to 2 days of release from the bone marrow. The retic count that you're probably most familiar with, which is typically 1 to 3% on average, is a percentage of cells that are reticulocytes. And so this is like your neutrophil count when you get like a 60% neutrophil count. And so it varies depending on the total hemoglobin. And therefore, relying on the absolute reticulocyte count is more accurate, just like relying on the absolute neutrophil count is more accurate. So after that blitzkrieg through CBCs, let's go on to talk about anemia and maybe apply some of those principles of the CBC interpretation that we just discussed. So first of all, let's talk a few minutes just about anemia in general. Whenever you're approaching a patient with anemia, remember that history is always the most cost-effective method of diagnosis. And that's true whether you're talking about anemia or you're talking about any kind of process, and that's not just hematology. But you want to ask about whether there's a family history of anemia, whether there's a prior personal history of anemia. A dietary history is very important, especially in pediatrics, where you have less chance for acquired causes of hemophilia. So you want to ask about whether they're vegetarian or vegan, and sometimes especially youngsters may not be practicing vegetarians, but in effect all they'll eat is potato chips or something of that nature. So you really want to get a dietary history. And then in your toddlers who have anemia, you want to ask about milk consumption. Menstrual history is very important, as is potential GI blood losses, as for identifying the cause of anemia. You want to ask about whether this patient had neonatal jaundice, or whether their siblings had neonatal jaundice. That might point you toward a hemolytic anemia. And then ethnicity is important as well, as that might point you towards a hemoglobinopathy or a thalassemia. So iron deficiency anemia, as a general pediatrician, is probably the most common anemia that you'll see. And the most common presentation of iron deficiency anemia in pediatrics is for toddlers who have excessive milk consumption. And probably right behind that is adolescent girls with excessive menstrual loss. So a toddler can replace their entire caloric intake with cow's milk. And they can drink half a gallon or more of milk in a day. And in that case, they're not only taking in a product that has very little iron availability or content at all, and a product that actually, cow's milk inhibits iron absorption in the human intestine. So if you're drinking that much milk, you're not only not getting iron, you're actually blocking the iron that you do get in, so that it's not available for absorption. Additionally, sometimes milk can irritate the GI mucosa, so you may have some blood loss or iron loss with excessive milk consumption as well. The other thing to remember with the menstrual history is that even young ladies that have normal menstrual cycles can develop iron deficiency if they're not taking adequate dietary iron. And so asking about what their dietary intake, again, is very important, because some people just say, oh, well, they have normal menses, so that's not the cause of their anemia, but that may not necessarily be true. So throughout the lecture, this slide reminds me that I've put in red things that may be important for you on your boards. I don't have any direct knowledge of this. I'm not on the board committee or anything of that nature, but things that I thought might be high yield. So when you're thinking about iron deficiency in the diagnosis, the CBC will demonstrate both microcytosis, so a low MCV, and hypochromia, so a low MCHC. Additionally, the RDW will be elevated, and actually often quite highly elevated. The retic count will be inappropriately low, so because you don't have any iron, you can't make any erythropoiesis, so you're not making red blood cells. Remember, and not to be misled, the serum iron is only an indicator of what you've had in within the last 6 hours. It's not a representative of your iron stores or general iron status. And then finally, the iron studies that will be abnormal in iron deficiency. The TIBC, or total iron binding capacity, will be elevated. The percent saturation, meaning how much iron is actually bound, will be low. And the serum ferritin, which is a marker of your iron stores, will also be low. So when we think about how to treat iron deficiency, treating is typically with elemental iron. Ferrous sulfate is still the main way to treat. There are alternative methods, but we still prefer the PO route. You need to replace with 4 to 6 milligrams per kilo of iron per day. You can divide that into to twice daily or 3 times daily dosing, just depending on ease. It requires about a week of treatment to start to see a reticulocytosis. So if you start somebody on iron and you check a hemoglobin or a CBC like 3 days later, you're probably not going to see any change. That doesn't mean they're not absorbing iron. The other important thing to remember is that you should not ever take iron with milk, because that will block the absorption. I typically find it's easier just to exclude cow's milk from the diet of toddlers who've developed anemia because of excessive milk consumption. And I would continue iron for 2 months after the hemoglobin normalizes to ensure that we've fully replenished the iron stores. There is an entity known as iron refractory iron deficiency anemia. However, the vast majority of these cases is due to non-compliance. Either they're just not taking the iron because it tastes horrible, or because they can't remember to take it. You can do an iron challenge, which is described here, to just make sure that they actually absorb their oral iron. In some cases, people with celiac disease or inflammatory bowel disease may not absorb their iron very well. So folate and B12 deficiency is the next deficiency anemia I'll mention. Folic acid deficiency is very rare in the United States. Flour is mandated to be supplemented with folic acid. Therefore, most people have plenty of folic acid in their diet. However, there can be dietary etiology, most notably in people who are alcoholics. So again, not usually very common in pediatrics. B12, on the other hand, is derived from animal products, primarily meat and dairy. So if you have somebody who's vegan or vegetarian, they may be more risk for dietary B12 deficiency than someone else. Pernicious anemia is an autoimmune disease that targets the intrinsic factor. And you'll remember from med school, intrinsic factor binds to B12 in the GI, or in the stomach rather, and essentially escorts it and provides safe harbor until it's somewhere it can be absorbed adequately. Pernicious anemia essentially targets the cells that make intrinsic factor so that your B12 cannot be absorbed adequately. It's also very rare in pediatrics. H. pylori, proton pump inhibitors, and histamine 2 antagonists have also all been associated with decreased B12 levels. So when you're thinking about diagnosis of folate or B12 deficiency, they're associated with a macro-ovalocytosis, so the cells are very big. Textbook is ovalocytosis, but you may actually have quite a variation in shapes with your red blood cells. The RDW will be elevated. Additionally, don't be misled because there are some markers of hemolysis that may be elevated due to intramedullary hemolysis, such as the bilirubin or the LDH. And when we say intramedullary, that means inside the bone marrow. And this may be some of the erythropoietic precursors. These deficiencies may be associated with other cytopenias. To diagnose them, you can directly measure folate or B12 levels. The RBC folate, which just means how much folate is within the red blood cell, is a better diagnostic tool than just the total serum folate levels. However, if you're looking, I would suggest looking at homocysteine levels and methylmalonic acid levels, which are both byproducts of the single carbon metabolism that B12 and folate are required for DNA synthesis. So these may be more sensitive and specific markers of B12 and folate deficiency than just measuring the vitamins directly. That brings us to hemolytic anemias, and these are intrinsic hemolytic anemias, meaning something that's wrong with the red blood cell and not something that's outside the red blood cell. Probably the most common cause of intrinsic hemolytic anemias is spherocytosis. And with these membrane defects, such as in spherocytosis, the red blood cell becomes fairly non-deformable, and as it passes through the microcirculation and through the reticuloendothelial system in the spleen, these cells rupture and then causes hemolysis. Specifically in spherocytosis, which is the most common, I'll remind you that is autosomally dominant, inherited. Therefore, the children will have a 1 in 2 chance, or a 50% chance rather, of inheriting spherocytosis. The red cells lose pieces of their membrane as they age, causing that iconic spherocytosis or spheroid shape, and leading to increased osmotic fragility. Elliptocytosis, xerocytosis, and pyropoikilocytosis are all other red cell membranes that probably are not going to be tested on your boards. Now, on the boards, probably they would list the diagnostic test for these as osmotic fragility, and that would be a correct answer. However, ectocytometry is essentially replacing osmotic fragility, and we perform that here, and essentially looks at deformability of the red cell membrane over a variety of osmotic concentrations. The other kinds of intrinsic hemolytic anemias to remember is those that interfere with glucose metabolism, because the red cell is very dependent on glucose metabolism for maintaining homeostasis. So pyruvate kinase deficiency and G6PD deficiency, which is probably the most common of these. I'll also remind you G6PD is X-linked in case that comes up on your boards. Immune-mediated hemolytic anemia, or autoimmune hemolytic anemia, is the other kind of extrinsic hemolytic anemia, as this is something outside the red cell. The most common form of this is warm agglutinin disease. Warm agglutinin is an IgG antibody that typically goes against fairly common antigens on the red cell surface. Because of this, cross-matching for transfusion is often very difficult. And the textbook answer here is, when you're treating these, to give the least incompatible unit, because otherwise you might see that your patient rapidly decreases their hemoglobin without transfusion. The other form of autoimmune hemolytic anemia is cold agglutinin, which is primarily with IgM antibodies. These are most common with infection or malignancy, and the most common situation with infection is Mycoplasma pneumonia. These IgM antibodies bind the red cell and fix complement rather than inducing direct phagocytosis of the red cell. And so sometimes on the Coombs test or the DAT, you'll see complement positive, which is your hint that it's a cold agglutinin disease. There is one IgG that paradoxically causes cold agglutination rather than warm agglutination, and that is the Donth-Landsteiner antibody. Essentially all you need to know is that's also known as paroxysmal cold hemoglobinuria. And the significance of warm versus cold, typically a lot of times you'll see that they put the blood on ice and they see agglutination after they've put the blood on ice to send to the lab or something of that nature. Sometimes you'll also see patients who've gone on bypass because they're being cooled will start to have problems with hemolysis more so than at baseline. And then thinking of genetic causes or other causes of anemia, a fairly common cause in pediatrics is called transient erythroplastopenia of childhood, or TEC, and this is really a fancy name for just saying you've got viral suppression of your erythropoiesis. Typically you present with a normocytic anemia, a low reticulocyte count. All your other testing is normal. However, parvovirus is the most common virus to cause this, and so getting parvoviral testing is recommended if you're looking at this diagnosis. And sometimes you catch them not as they're at their nadir, but as they're recovering, and you might see a macrocytosis, and that's usually transient as their bone marrow is recovering from that stress of being virally suppressed. Diamond black fan anemia, or black fan diamond, is a pure red cell aplasia. It's a genetic cause of bone marrow failure because of a defect in ribosomal function. These may respond to corticosteroids. Again, it's a very rare cause of anemia. So when we think about hemoglobin, remember that hemoglobin is not a single protein, but rather it's a heterotetrameric protein, meaning that there's 4 chains and they're not all the same. The thing that is the same in all hemoglobin molecules is that they all have 2 alpha chains in all but embryonic hemoglobin. So, and then depending on what other chains are available, it depends on what kind of hemoglobin you have. So if you have 2 alpha chains with 2 gamma chains, that is hemoglobin F. If you have 2 alpha chains with 2 beta chains, that's hemoglobin A. And if you have 2 alpha chains with 2 delta chains, that's hemoglobin A2. So you remember that humans have 2 beta genes, but most people don't remember or don't realize that you actually have 4 alpha globin genes. And so that makes thinking about alpha thalassemia a little difficult, and we'll talk about that a little more under thalassemias. So the most common hemoglobinopathy and most well known is sickle cell disease. And sickle cell disease results from a single amino acid substitution. You probably need to know that, but not the actual substitution. It was actually the first molecular disease described by Linus Pauling in 1949. And this mutation results in polymerization of the hemoglobin S molecules when the hemoglobin is deoxygenated. And so because of those long chains of hemoglobin, it causes distortion of the red blood cell and causes it to go from that normal kind of donut shape into a sickle shape that you can see under a microscope, which really led to it being named sickle cell disease. Because of these are very rigid blood cells that causes microvascular occlusion and hemolysis. This microvascular occlusion can lead to pain crises. You can get it bone necrosis, renal disease, stroke, acute chest syndrome, splenic infarction. Really, sickle cell disease is a multi-organ disease. Even though it's really primarily a red blood cell disorder, it affects every organ in the body. So when you have someone with sickle cell disease, remember their spleen, even if they haven't fully auto-infarcted it yet, is not normal. And so they are at risk for encapsulated bacterial infections. And we recommend penicillin prophylaxis, and we recommend that till at least age of 5. Once they get to 5, we let the parents decide if they want to continue or not. In anyone with sickle cell disease and fever, you should get a blood culture and consider antibiotics, or they should receive antibiotics because of the risk of bacterial sepsis. Effective pain control during acute crisis is very important, not only to make the patient more comfortable, but to make sure they're adequately ventilating. Inadequate ventilation during acute pain crisis often leads to acute chest syndrome. And then acute chest syndrome is likely a combination of causes. The lung is the only organ that can convert a sickle cell back to a normal red blood cell shape by oxygenating the hemoglobin. So if you're having something like a pneumonia going on there, then you can't convert those cells back. So you may get sickle vasal occlusion in that area, and that sets up a chicken and the egg for infection. So it may be infection that gets the ball rolling, it may be sickle vasal occlusion that gets the ball rolling, but we treat them for both their sickle process as well as for their for infection. And remember, patients who present with acute neurologic changes and sickle cell disease need emergent evaluation and consideration for transfusion because of the significant risk of stroke associated with sickle cell disease. So when you're thinking about how to treat sickle cell disease, hydroxyurea is the only FDA-approved drug for sickle cell disease. It stimulates hemoglobin F production. It stimulates stress erythropoiesis of the bone marrow and increases F levels. And F is more effective than hemoglobin A in interrupting sickle polymer formation. So you don't need as much F as you do A to stop that polymer from forming. In patients who've had acute chest syndrome, recurrent acute chest syndrome, or stroke, chronic transfusions are the indicated treatment. But remember that sickle cell patients may become iron overloaded from transfusions. Therefore, to avoid end organ damage such as liver and heart, iron chelation is necessary to remove all that excess iron. So we'll talk briefly about the thalassemias. And thalassemia is a general word that just means poor red blood cell production. And there can either be beta or alpha thalassemia. And beta thalassemia is because of a lack of production from the beta globin gene, a mutation in the beta globin gene. And you can have a spectrum of beta thalassemia, all the way from essentially having no beta globin to having decreased or almost normal beta globin levels. But this ratio of alpha to beta is very important, because if you have increased alpha to their beta ratio, you get ineffective erythropoiesis, you get hemolysis of the erythropoietic cells, and decreased red blood cell lifespan. So in addition to just not making cells very well, your cells that are made are not as stable as normal red blood cells. Beta thalassemia may be inherited with hemoglobin S, and that may result in a more sickle cell spectrum of disease as well. And then in beta thalassemia major, where you have very little beta production, because your body's trying to keep up with the demands and make more red blood cells, you may need to start hypertransfusion to suppress erythropoiesis, so you don't get bony changes and other stigmata that are associated with that hypererythropoiesis. Alpha thalassemia, and again, remember I said that alpha thalassemia is typically harder to understand than beta thalassemia, and that's because there are 4 alpha genes, 2 of course from mom and 2 from dad, and there's a variation depending on the number of genes deleted. So with a 1 gene deletion, typically those patients have no symptoms at all or completely silent. A 2 gene deletion is called alpha thalassemia trait, with either mild anemia or maybe normal hemoglobin with some microcytosis. These patients may be identified on newborn screen because they have hemoglobin BARTs, which instead of having 2 alphas and 2 Fs or gammas, you have 4 gammas, which is known as hemoglobin BARTs. You may have a 3 gene deletion, which is also known as hemoglobin H disease. And this is because patients don't have enough alpha in their red blood cells. And so the betas form a tetramer. So you have 4 beta proteins together, and that's hemoglobin H. It's a very unstable hemoglobin and leads to very excessive hemolysis. And again, BARTs would be present on the newborn screen. And then a forward gene mutation is hydrops fatalis. Essentially, that means zero blood. It's incompatible with life, and it's lethal, potentially in utero or immediately after birth, without intervention by fetal surgery and intrauterine transfusion. You may run across hemoglobin constant spring. It's just an alpha gene mutation that results in decreased alpha production. Okay, well, that's probably all the anemia you can handle at this point. So we're going to move on to neutropenias and talk about white blood cells for a short period of time. So neutropenia is typically defined as an absolute neutrophil count that it's less than 1,500. However, it's rarely problematic if your neutrophil count is over 1,000. And probably the most common etiology is viral suppression. We see this all the time, as do you. And so that's why we don't recommend doing the full workup for neutropenia on the very first CBC where neutropenia is revealed. Rather, we would suggest a tincture of time, give them some time to resolve whatever may be going on at that time, especially if they're otherwise well, and then repeating the CBC at a later date. I don't believe I included this in the lecture, but there's also an entity known as ethnic neutropenia. African Americans as a group tend to have a lower ANC than other ethnic groups. This is associated with Duffy null status. So Duffy is a blood group antigen, and if they don't have this Duffy antigen on their cell surface, they tend to have a lower neutrophil count than those that do. Autoimmune neutropenia, especially in pediatrics, is another very common etiology. This is also known as benign neutropenia of childhood because it is rarely associated with severe infectious complications. However, occasionally some patients will develop an infection, or they need surgery or something like that, and you need to boost their neutrophil count, and G-CSF should be very effective in this situation. There are also several congenital neutropenias. Cyclic neutropenia may be associated with cyclic fevers. The cycles can range from every 14 to 35 days and is associated with elastase mutations. You have to measure these CBCs twice weekly to make sure that you're really capturing the cycles. Schwachman-Diamond is a congenital neutropenia that may progress to bone marrow failure and or leukemia. This is interesting because it actually kind of looks like cystic fibrosis in that they have pancreatic exocrine insufficiency and may have failure to thrive as well. But the difference is that, of course, these patients have no pulmonary manifestations. And then the final one that I'll mention is Kostman syndrome, or severe congenital neutropenia. And right now, there are two genes that have been identified to cause this. These may or may not respond to G-CSF, and typically are associated with progression to myelodysplasia and or leukemia. So we'll talk briefly about bone marrow failure. So let's talk about how to evaluate a patient with pancytopenia. So pancytopenia, you see a patient that has maybe 2 or more cell lines down. You should consider bone marrow failure and or malignancy. When you're looking at leukopenia, really look at why is the patient leukopenic. Is it because they have a low lymphocyte count, or do they have a low neutrophil count? Or is it none of the above? I can tell you I get numerous referrals for leukopenia, but their total lymphocyte count is normal and their total neutrophil count is normal, and I typically don't proceed in working those patients up. Is the red blood cell macrocytosis present? That may be an indicator of etiology, most notably of bone marrow failure. Is there evidence of tumor lysis? And that might be increased LDH, uric acid, potassium, or decreased calcium. And remember that absence of peripheral blasts and the absence of tumor lysis syndrome still does not exclude leukemia. So you may have leukemia with every other lab being normal. So at the end of the day, really to determine if this is a bone marrow failure versus malignancy versus another cause, then you will need to do a bone marrow aspirate and biopsy to really fully make the diagnosis. So aplastic anemia. Aplastic anemia is essentially immune-mediated bone marrow failure. So this is an immune response against the hematopoietic precursors. The antigen that is the primary target has not been necessarily identified. But aplastic anemia, especially in older teens and adults, is typically more common than other congenital forms of marrow failure. So the primary and preferred route of treatment for aplastic anemia, other than supportive care, is a bone marrow transplant, especially if a matched sibling donor is present or available. In the absence of a matched SIB, then often they'll proceed with immunosuppression using ATG, antithymocytic globulin, and cyclosporin. But typically, like I said, this is the second choice or second preferred route. I'm going to mention paroxysmal nocturnal hemoglobinuria, or PNH. And these are essentially when you acquire a clone of stem cells that lose PIG-A expression or CD59 expression on the blood cells. And this is a cellular protein that renders the cell more sensitive to complement-mediated destruction. And so because of this, you can see cytopenias associated with this complement-mediated destruction. You may even have pancytopenia. It may provide a survival advantage for the stem cell clone that has PNH. And this is especially true in patients who've developed aplastic anemia. So sometimes you'll see a patient develop aplastic anemia and then evolve into having PNH. Because you're breaking down all these red blood cells, well, not really red blood cells, platelets and white blood cells, you're really putting the patient at significant risk for developing a thrombosis. And so when you see a patient with specifically a big thrombosis, and usually like an intra-abdominal thrombosis, like a portal vein thrombosis, a new portal vein thrombosis, then you typically consider PNH as a possible etiology. Solaris, also known as eculizumab, is approved for treatment and just shuts down the complement-mediated destruction of these cells. There are also congenital bone marrow failure syndromes. Fanconi's anemia is a problem with your DNA repair mechanism. Fanconi's has a specific facies and syndromic appearance, but in addition to that, they also maybe have radial abnormalities with absent thumbs and or radii. Dyskeratosis congenita is a loss of telomere maintenance leading to bone marrow failure. Amegakaryocytic thrombocytopenia is a mutation in thrombopoietin receptor, typically starting with thrombocytopenia but then migrating into bone marrow failure. And then thrombocytopenia absent radii syndrome, or TAR syndrome, typically only presents with thrombocytopenia. These may also not have radii, so but they have thumbs. So if you have a patient with thrombocytopenia, missing radii, but they have thumbs, think TAR before you think Fanconi's. Patients with TAR syndrome also tend to get better as they get older, whereas patients with Fanconi's do not. And so finally, we're going to end up with a discussion of hemostasis and platelets. So remember, platelets are small, really not cells, but cell fragments that are necessary for initial hemostasis. Excuse me. We used to call platelets primary hemostasis as if it occurred in a vacuum, but really platelet activation and the hemostatic cascade happen simultaneously and don't occur in a vacuum. So platelets can be activated by a whole host of agonists that lead to aggregation and localization to the site of vascular injury, resulting in a platelet plug. You require fibrinogen for this process, so in the complete absence of fibrinogen, your platelets can't aggregate to almost all agonists. Therefore, fibrinogen is very important. Von Willebrand factor is also important in that von Willebrand factor essentially provides a link between the subendothelial collagen and the platelet via the receptor GP1B. And so patients without von Willebrand factor may have platelet-type bleeding. So the absence of platelets, and probably most of you have seen an ITP patient at this point in time, is highlighted initially by spontaneous petechiae and ecchymosis. And typically they may have more significant bleeding, epistaxis. They can even have spontaneous intracranial hemorrhage. However, remember that isolated petechiae may be associated with thrombocytopenia, but it's not typically associated with platelet function defects. What do I mean by that? So in patients who have petechiae only and not bruising and not bleeding, that is not indicative of a bleeding disorder unless they have thrombocytopenia. So ITP, or immune-mediated thrombocytopenia, is antibody-mediated platelet destruction. This may be isolated or a symptom of another autoimmune syndrome or immunodeficiency. Most commonly, lupus, HIV or AIDS, and ALPS are associated with ITP as well. The treatment is needed when there's mucosal bleeding, hematuria, other signs of bleeding, but you don't necessarily need to treat a number alone. So if a patient looks well, has a platelet count of 2 or 5 or what have you, and they're not bleeding, then you may observe alone. And evidence points to the fact that treatment with anything early on does not change the course of whether this patient's going to resolve in the long term. IVIG Winro, which is an anti-D or anti-RH antibody, or corticosteroids are typically the first line of treatment. In the second line, there's a new line of TPO mimetics, essentially analogous to GCSF for neutrophils, so you're driving increased platelet production. Rituximab may be useful in trying to delete the B cell line that's producing the antiplatelet antibody. And then splenectomy is usually reserved for those that are refractory to other forms of therapy. So platelet function disorders may also be a cause of bleeding. And there are a host of platelet disorders, but probably the two you would need to know about are Glanzmann's thrombosenia. And Glanzmann's, remember I told you that fibrinogen is absolutely required for platelet aggregation. So Glanzmann's is the loss of the fibrinogen receptor on the platelet surface. So if you, again, can't bind fibrinogen, you cannot have platelet aggregation, and this is a very severe platelet defect. These patients have really severe bleeding and spontaneous bleeding syndromes. Bernard-Soulier is loss of the von Willebrand binding receptor. Bernard-Soulier, unlike Glanzmann's, has a macrothrombocytopenia, meaning the platelets are large and they're reduced in number. However, unlike Glanzmann's, this is more of a moderate bleeding disorder. They don't have as severe bleeding as patients with Glanzmann's do. Von Willebrand's disease is worth mentioning as the most common bleeding disorder, affecting about 1% of the population. Von Willebrand factor is a very large multimeric protein. Again, like I said before, it bridges the platelets from the subendothelial collagen to the platelet receptor GP1B. But in addition to its role in helping with platelet aggregation, von Willebrand factor is also a carrier for clotting factor VIII. So in the absence of von Willebrand's factor, you can have a very low factor VIII, because factor VIII's half-life in circulation is very short in the absence of von Willebrand's factor. Again, it's the most common disorder. There are 3 types depending on the abnormality associated with von Willebrand factor. Much like platelet disorders, von Willebrand disease is associated with mucosal bleeding or bleeding after surgery. Heavy menstrual bleeding is another common symptom. And this may be treated with DDAVP, which stimulates release of endogenous von Willebrand factor, or replacement of the von Willebrand factor with plasma-derived von Willebrand factor. And there are numerous concentrates available. And finally, I'm going to spend just a minute or two on hemophilia. Hemophilia A is factor VIII deficiency and occurs at about 1 in 5,000 male births, whereas hemophilia B is factor IX deficiency and occurs in about 1 in 30,000 male births. So factor VIII is a lot more, or hemophilia A is a lot more common than hemophilia B. They're both called hemophilia because factor VIII is a cofactor for factor IX, and essentially they have a almost identical clinical phenotype and presentation. So just by their symptoms alone, it's often impossible to determine if a patient has hemophilia A or hemophilia B. So you need to do the lab work to definitively characterize that. So hemophilia is characterized by musculoskeletal bleeding, and the kind of characteristic bleed associated with hemophilia is the hemarthrosis. These are also associated with bleeding after surgery or bleeding after trauma. Both hemophilia A and hemophilia B, factor IX and factor VIII, are X-linked. Therefore, females are typically carriers, and males are typically the ones affected. However, that's not always the case, because the X chromosome can be lionized, meaning one is inactivated at birth, and it's not always 50-50. Sometimes one X chromosome is inactivated more than the other. Therefore, some women are more severely affected than others. At Children's, we've had 2 patients while I've been here that have had severe hemophilia A, even though they both only have 1 copy of the factor VIII gene, abnormal factor VIII gene. And so just thinking about hemophilia inheritance, and the reason I'm going through this is because on my board research, the only hematology question I was asked was about hemophilia inheritance. And so when you have an affected male and an unaffected female, all male children will be unaffected, and all female children will be obligate carriers of hemophilia. So no males will be affected at all, but all females have to be carriers of hemophilia if the father has hemophilia. On the other hand, if the father does not have hemophilia and the mother is a carrier of hemophilia, the female children will have a 50% chance of being a carrier, and the male children will have a 50% chance of being affected. So if you look at essentially a pictorial diagram of this, here you have an affected male and an unaffected female, and they have a child. They have a 50% chance of having an unaffected boy, or a 50% chance of having a carrier girl. On the other side of the coin, if you have an unaffected male and a carrier mom, and they have a child, they have a 25% chance of having an affected boy, a 25% chance of having an unaffected boy, a 25% chance of having an unaffected girl, and a 25% chance of having a carrier. So that wraps up the lecture on hematology. If any of you have further questions, feel free to give me an email. Thank you very much.